Hi everyone, my name is Divya Reddy and I'm an assistant professor in the Pulmonary division. My goal with this lecture is to give non-critical care medicine staff an understanding of some basic concepts pertaining to mechanical ventilation. My colleague, Dr. Vivek Murthy, will then discuss management of acute respiratory distress syndrome. During this talk, I will be going over indications for mechanical ventilation, discussing some common ventilator modes and manipulations that can be done to improve oxygenation and ventilation. We will also be troubleshooting some ventilator alarms before finishing up with a common ventilator weaning protocol. Respiratory failure is by far the most common indication for mechanical ventilation. There are two types: hypoxic respiratory failure, which occurs due to an inability to oxygenate, and hypercapnic respiratory failure, which occurs due to an inability to ventilate. There are three common causes for hypoxic respiratory failure. The first one is VQ mismatch. This occurs when a part of the lung receives oxygen without blood supply and a part receives blood supply without oxygen. Common examples are pulmonary hypertension, interstitial lung disease, bronchiectasis, and PE. Second cause is a right to left shunt. It's essentially an extreme form of VQ mismatch. Examples are atrial and ventricular septal defects, AV malformations, and ARDS. It's important to note that supplemental oxygen doesn't improve O2 sats significantly in these situations. Hypoventilation due to drug overdose or neuromuscular weakness is another example of hypoxic respiratory failure. Most common causes of hypercapnic respiratory failure are asthma and COPD exacerbations. The next indication for mechanical ventilation is loss of airway anatomy in situations such as anaphylaxis, burns, and infections such as epiglottitis. Lastly, encephalopathy and loss of protective airway mechanisms resulting from intoxicants and cerebrovascular accidents is another common indication for mechanical ventilation. Several companies make mechanical ventilators, and the screens vary by brand. Some are touchscreen, while some have dials to change the parameters. This is what it commonly looks like, and I wanted to go over some numbers that are important for us. The first set are the ones down here at the bottom. These are the parameters that we set based on the mode of ventilation and patient's oxygen requirements. FiO2 is the concentration of oxygen in the inspired air. PEEP, or positive end expiratory pressure, is the pressure remaining in the lung at the end of expiration. Now, FiO2, PEEP, and respiratory rate are set irrespective of the kind of ventilator mode. Tidal volume is the volume of gas exchanged with each breath, and it is set in volume preset modes. Inspiratory pressure is the additional pressure given during inspiration to ensure a larger tidal volume. This parameter is set primarily in pressure preset modes. The numbers here on the right are calculated by the ventilator. P-peak, or peak inspiratory pressure, is the pressure measured at the end of a breath delivery. This is the actual respiratory rate. This number includes the number of spontaneous breaths taken by the patient as well. VTE is expiratory tidal volume and VTI is inspiratory tidal volume. These two numbers should be very close to each other. Significant difference may be suggestive of a cuff leak. MV, or minute ventilation, is the volume of gas exchanged per minute. It is defined as respiratory rate multiplied by tidal volume. There are several ventilator modes. For the purpose of this talk, we will cover volume assist control mode, pressure assist control mode, pressure regulated volume control mode, and pressure support ventilation. AC, or assist control, basically means that the mode supports patient-initiated and ventilator-initiated breaths with a guaranteed tidal volume. This table compares the different modes. With volume assist control mode, the ventilator delivers a set tidal volume with each assisted and controlled breath. The number of controlled breaths is also set. With pressure assist control mode, the ventilator delivers a breath until the set inspiratory pressure is reached. So in a way, we are limiting the peak inspiratory pressure. The number of controlled breaths is set here as well. PRVC is a dual ventilation mode. It's considered to be more physiologic, more comfortable. What happens here is that the ventilator triggers a pressure breath to give a set or target tidal volume. So although we set a tidal volume, it's a pressure mode. This mode is very helpful in situations where the lung compliance changes over time. Lastly, in pressure support mode, we set an inspiratory pressure to augment spontaneous breaths. A backup respiratory rate is not set in this mode. So if there is no patient effort, apnea would be recorded. Let's talk about some waveforms. These are the ones seen in pressure preset modes. X-axis shows time. The orange waveform shows pressure. The green waveform shows flow, and blue waveform shows volume, mainly on the y-axis. The baseline for the pressure waveform is a measure of the set PEEP. During inspiration, the pressure is kept constant at the set inspiratory pressure. The flow above zero is the flow delivered to the patient, and the flow below zero is the flow delivered from the patient. The flow curve depends upon the set inspiratory pressure, lung compliance, and airway or circuit resistance. During inspiration, the flow rises until the set inspiratory pressure is reached. Thereafter, flow decreases while pressure is kept constant. As expiration starts, the pressure decreases with a high flow rate. And as lung pressure decreases, the flow decelerates until it reaches zero. If you see here, during inspiration time, volume curve increases, and during expiration time, the volume curve decreases. These are the waveforms in the volume preset modes. Compared to the waveforms in the pressure preset modes, the tidal volume is delivered at a constant flow. Another difference is the presence of an inspiratory pause. During this period, no gas is delivered and the pressure will consequently drop. Now, how much it drops is dependent upon the airway resistance. At the start of inspiration, the pressure in the lung is at the set PEEP. After a short while, the target flow is reached and kept during inspiration. During the pause time, flow stops and pressure is kept constant, which means volume doesn't change. The volume that is delivered is exhaled during expiration, and the pressure level reaches the same PEEP level as when the inhalation started. These waveforms represent PRVC. They are similar appearing to those in pressure preset modes. Here, a tidal volume is set in addition to an upper pressure limit. During inspiration, the pressure keeps rising as long as it's below the upper pressure limit until the target tidal volume is achieved. All right, let's talk about a clinical scenario where an intubated patient's ABG comes back as pH of 7.41, PCO2 of 43, PaO2 of 52, and O2 sat of 83%. Patient is in hypoxic respiratory failure. What changes can we make on the ventilator to improve the hypoxia? FiO2 and PEEP are the main parameters that control oxygenation. FiO2 is easy to administer, and increasing it does not increase the risk of barotrauma. The main disadvantage is the direct oxygen toxicity associated with 60% or higher FiO2. It also fails to affect VQ mismatching. Increasing PEEP maintains FRC, or functional residual capacity, and prevents lung collapse. However, it worsens lung compliance. The lungs become stiffer. It can cause hypotension due to decreased venous return and increased dead space ventilation as well. Here is a clinical scenario where your intubated patient has an ABG of 7.09, PCO2 greater than 100, PaO2 of 74, and O2 sat of 95%. The patient is hypercapnic. What are some of the things that you can do to improve ventilation? One can increase respiratory rate, increase tidal volume, increase inspiratory pressure, or decrease PEEP. Now, respiratory rate is easy to titrate and minimizes barotrauma. One has to be careful, however, as a very high respiratory rate can shorten the respiratory cycle and prevent full exhalation, leading to air trapping and high PEEP. Tidal volumes are easy to titrate, and the only risk is volutrauma. In pressure preset modes, increasing inspiratory pressure will allow for higher tidal volumes. High inspiratory pressures can decrease lung compliance and also increase risk of barotrauma. Decreasing PEEP reduces death place and improves ventilation. It can, however, decrease mean airway pressures and oxygenation as well. Now let's troubleshoot a few scenarios. One of the most common alarms to go off on the ventilator is this one. PEEP peak, or the peak inspiratory pressure, is elevated, and the ventilator screen will say airway pressure is high. Now what do we do? This is the pressure waveform during inspiration in volume preset modes. It shows us the various pressures that constitute the peak inspiratory pressure. Again, the peak inspiratory pressure is the pressure measured at the end of a breath delivery or inspiration. Plateau pressure, which you see here, is the pressure measured after a breath hold of 1 second. It's a measure of lung compliance. Now, the difference between the peak inspiratory pressure and the plateau pressure is the pressure required to overcome airway resistance. So if the peak inspiratory pressure is high, perform a breath hold maneuver after ensuring the ventilator is in a volume preset mode. If the difference between P peak and P plat is less than 13, meaning the plateau pressure is very close to peak inspiratory pressure, then it is a lung compliance issue. Lung compliance is poor in conditions such as pneumothorax, lung collapse, ARDS, and pulmonary edema. If the difference is greater than 13, then it's an airway or circuit issue. We can see this in bronchospasm, mucus plugging, or even when the patient bites the ET tube. Treating the underlying issue, decreasing PEEP, tidal volume, or switching to a pressure preset mode oftentimes will decrease these pressures. Now let's talk about the pressures at the end of expiration. Positive end expiratory pressure is maintained in the alveoli, which prevents lung collapse during expiration. Total PEEP is a measure of intrinsic PEEP or auto PEEP and set PEEP. Now, when the respiratory rate is set too high or expiratory time is not long enough, expiration can be incomplete, resulting in trapped air and high auto PEEP. This typically can be seen on the flow curve. If you see here, the expiratory limb does not return back to zero. Oftentimes, decreasing respiratory rate or increasing expiratory time will fix this issue. Next, we're going to touch upon ventilator dyssynchrony. What exactly is it? It mainly occurs when the timing of the ventilator cycle is not simultaneous with the timing of the patient's respiratory cycle. It results in increased work of breathing, patient discomfort, hypoxemia, lung overdistension, prolonged mechanical ventilation, and neuromuscular complications from prolonged immobility. How to recognize ventilator dyssynchrony? First of all, the patient will look uncomfortable, will look restless. And if you look at the ventilator waveforms, the breaths may not look identical, like here. There can be some dips and bumps, like here and here. And the curves in general will not be smooth. These are just some examples. Troubleshooting these individual waveforms is outside the scope of this lecture. But remember, dyssynchrony occurs only when there is patient effort. Oftentimes, a bolus of sedation or increasing the drip rate will provide some relief. Lastly, I wanted to touch upon ventilator weaning. The goal is to wean to settings that provide minimal ventilator support. We typically think of FiO2 less than 40% and PEEP less than 8, or FiO2 less than 50% and PEEP less than 5 as minimal vent settings. If the patient is clinically improving, hypoxia is resolving, then the first step should always be to wean FiO2. Remember, oxygen exhibits direct toxicity to the lung over 60%. The next step would be to wean PEEP. This can be done by decreasing PEEP by 2 points and assessing the O2 sat and or PaO2 on the ABG. Now remember, aggressive weaning can lead to alveolar de-recruitment and should be avoided. Once PEEP requirements are less than 8, then FiO2 can be weaned down to less than 50%. When is the patient ready for a spontaneous breathing trial? The patient is considered to be ready when the cause of the respiratory failure has improved. Patient is awake and following commands, has minimal secretions, is on minimal ventilator support, pH is greater than 7.25, and the patient is hemodynamically stable. How do we conduct a spontaneous breathing trial? When the patient is ready, place the patient on pressure support of 5 and PEEP of 5 and assess tolerance. Is the O2 sat greater than 90%? Are the tidal volumes adequate? There should be no respiratory distress, no tachycardia or tachypnea. If the patient is able to spontaneously breathe for about 2 hours, it typically suggests that the patient is ready for extubation. In a non-critical care setting, however, it is reasonable to attempt SBTs over a few days. And if the patient does well, then he or she may be a good candidate for extubation. This is the last of my slides. I hope they are helpful. I'm going to now hand it over to Dr. Vivek Murthy, who's going to be covering the basics of ARDS and its management. Thank you.
Thank you, Dr. Reddy, for that introduction. So my name is Vivek Murthy, and I'm a pulmonologist with Montefiore. I'll be talking a little bit about some of the pulmonary complications we see with COVID-19, and in particular, how we manage ARDS and its various manifestations in this illness. So why are we seeing ARDS so often in these patients? And ARDS, I should probably mention, is acute respiratory distress syndrome, which is a common pathway for many inflammatory conditions affecting the lung, both infectious and non-infectious. So why does COVID-19 seem to so particularly lead to this complication? Well, the respiratory tract is the primary target of coronaviruses in general, from the moment of infection, from the upper respiratory tract, down to the fact that type 2 pneumocytes in the lung seem to be a particular area of focus for infection. Type 2 pneumocytes serve a number of functions. Their two most important functions are, number one, generating surfactant, which, as you know, decreases surface tension and enables the lungs to expand and contract smoothly. And number two, type 2 pneumocytes are responsible for alveolar repair. Though they comprise 60% of cells in the alveolar surface, they actually only occupy 5% of the surface area. So they're very small but very important and numerous cells. They can de-differentiate to type 1 pneumocytes when they're damaged. So they serve a very important function in the normal homeostasis of the lung and in the repair mechanisms of the lung, which is why when they're damaged and targeted by COVID-19 infection, the effects on the lung can be so devastating. So what do we see in terms of the clinical manifestation and the pathologic manifestations of COVID-19 infection? Well, we know when the lungs are involved in a severe way, we see a pattern pathologically of diffuse alveolar damage, of injured bronchiolar epithelium, which predisposes to secondary bacterial infections. We see deposition of hyaline membrane. As I mentioned, damage to and hyperplasia of type 2 pneumocytes. It's edema in the interlobular septae of the alveoli and lymphocytic infiltrate. Basically, what I'm describing to you with all the above is ARDS, and it's all part of the natural history of severe coronavirus infections. So not everyone, as we know, not everyone who has a COVID-19 infection necessarily develops these severe manifestations, and risk factors for hypoxic respiratory failure, which occurs in some degree in about 20% of patients, include age over 60 years, being male, having diabetes, underlying cancer, or being immunocompromised in some way. And for patients who do present this way, the pattern of progression is often very kind of pathognomonic. When hypoxic respiratory failure develops, the progression is often rapid from its initiation. Within 12 to 24 hours of onset, we see that patients can go from mild to very severe symptoms. The median time from the point of infection to developing ARDS is around 8 to 12 days. The time to mechanical ventilation parallels that. It's around 10 to 14 days. And upon intubation, we know that the median time to developing a ventilator-associated pneumonia is around 8 days. And as I mentioned earlier, it seems like these patients are predisposed to secondary bacterial infections due to the mechanism of infection. So just to have a sense of what the clinical course of these patients looks like, some of the early data from Wuhan are presented here, published in Lancet earlier this year. In a cohort of 190 patients who ultimately required ICU admission, they looked at the clinical characteristics for survivors versus non-survivors. And in this cohort, 28% of patients fell into the non-survivor group. So what they saw, I think the similarities are far more striking than the differences. And you could almost interpose the survivor and non-survivor cohorts up until around day 12, which is when they start to diverge. So fever, cough, dyspnea all occur in roughly the same median time frame. Where they differ is in non-survivors, far more of them required invasive ventilation, mechanical ventilation. Only one of the survivors, less than 1%, required intubation, whereas 57% of the non-survivors required intubation. So I think the takeaway here is that for the first week and a half of their hospitalization, these patients may not actually look all that different, besides perhaps some underlying demographic or comorbid factors that may predispose to this severe phenotype. So what do we do about managing hypoxic respiratory failure in these patients? Not all of them will develop frank ARDS, but the ones that we're taking care of in the hospital are going to have some degree of hypoxia, very likely. Very helpfully, the Society for Critical Care Medicine just released some guidelines based on available evidence, both pertaining to COVID-19 specifically and to what we know about hypoxic respiratory failure in general. And I'd like to present some of the most salient recommendations that they provide here and talk a little bit about some of the data underlying those recommendations. So first of all, oxygen targets. So for patients with COVID-19 pneumonia, they suggest providing supplemental oxygen if the peripheral O2 sat is less than 92%, and they recommend it if the saturation is less than 90%. They also recommend avoiding a saturation greater than 96% with supplemental O2. So where do the data for this come from? Regarding targeting a high oxygen saturation, we know from a number of randomized controlled trials, as well as a major meta-analysis kind of encompassing all of these trials that was published in 2018, that when you target a saturation of greater than 96%, meaning a liberal oxygenation strategy, that there's actually an increase in mortality with a hazard ratio of 1.1 as compared to when you target a more conservative approach. So small difference, but notable, and associated with worse mortality when you target a saturation of 100% in every single patient with supplemental oxygen. On the other end, so these are just data from the meta-analysis that I mentioned, where after 15 days, we see that there's a separation in the mortality curves that seem to persist way out from the initial randomization. On the other end, particularly in ARDS, we know that there are potential risks for targeting a lower saturation. So there was a very recent, just about 2 weeks ago, recently published trial looking at conservative versus liberal oxygenation targets in patients with ARDS. So patients were randomized either to an oxygen saturation goal of 88 to 92% or to a goal of greater than 96%. So this trial was actually stopped early after the first 200 patients because there was an increased signal for death from any cause in the conservative oxygen arm. And not only was there a higher risk for mortality, but actually there were frank mesenteric ischemic events all in the conservative oxygen group. So too much oxygen might be a problem, too little obviously is associated with worse outcomes. What is the sweet spot that we should be targeting for our inpatients? Another very hot off the press study just published last week in CHEST, done by a group in Singapore, looked at 2 large data sets of ICU patients to try to answer this question of, if too much isn't good, if too little isn't good, what should we be aiming for? And they looked at hourly oxygen saturation data and the risk of, they plotted it against the risk of in-hospital mortality. And what they found was, just as has been described, that there were risks at either end of the curve, but when you targeted this range of 94 to 98% or so, particularly around 95, 96%, that's where the mortality seemed to be lowest. And this is true even when adjusting for age, BMI, gender, severity of illness score, and more time spent in this range was associated with lower mortality as well. So this is all the data that's underpinning this goal of targeting a saturation of 92 to 96%. Now, if your patient is 100% on room air, obviously this doesn't really apply to them, and maybe they shouldn't be in the hospital in that case, but this is really for people requiring supplemental O2. So let's say you have a patient on supplemental oxygen and they're not really doing so well. They're still hypoxic despite that. What should the next step be? The recommendation from the Society for Critical Care Medicine is that for patients who are failing conventional oxygen therapy, they suggest using high-flow nasal cannula as the next step. What do we know about high-flow nasal cannula? And I'll talk towards the end of this a little bit about the modality, some of the specifics regarding using the modality. But basically what we know about high-flow nasal cannula is that when we're using it in patients with respiratory failure, it may reduce the number of patients who require intubation, probably does not impact mortality or hospital length of stay, and probably does not increase the risk of transmitting COVID-19 infection. So again, data from a number of high-quality randomized clinical trials was combined in a meta-analysis looking at patients who had hypoxic respiratory failure who were randomized either to receiving high-flow nasal cannula versus conventional nasal cannula therapy. So these patients who were randomized to high flow had a lower risk for requiring intubation with a relative risk of 0.85, not too much of a difference in mortality overall. And data on the risk of transmission are limited, but what we know from a analysis done from a group in Toronto during the 2003 SARS coronavirus infection, SARS-CoV-1, that patients who were intubated, patients who had non-invasive ventilation on, the risk of transmission to healthcare workers was significantly increased, but that was not observed with high-flow nasal cannula. This concern has been raised because you're taking very high flow rates with heated, humidified air. But despite this theoretical concern, in practice, this has not really been demonstrated. So speaking of non-invasive ventilation, what about non-invasive? You know, we're accustomed to using it for patients who are tachypnic, who aren't looking well, who look like they might require non-invasive, might require intubation, or who are very hypercapnic. So in a patient who we have these thoughts about, who has a coronavirus infection, the recommendation from the Society for Critical Care Medicine is that when feasible, that they suggest using high-flow nasal cannula over non-invasive ventilation. What are the data supporting this? Well, we don't have really much on COVID-19 specifically, but looking at data from the last major coronavirus outbreak, which is the Middle East respiratory syndrome virus, also a coronavirus, a retrospective study looking at 302 critically ill patients with MERS who received non-invasive ventilation. 92% of those patients went on to require intubation. There's no difference in mortality or ICU length of stay for these patients. Also, in a very high quality meta-analysis that was done looking at the three major modalities that we use, high flow, conventional oxygen therapy, or non-invasive ventilation, both nasal cannula and non-invasive were inferior to high flow nasal cannula. So the odds ratio for requiring intubation and patients were on high flow versus non-invasive was 0.48. And perhaps more importantly, the risk for ICU mortality odds ratio was 0.36 for high flow versus non-invasive ventilation. So I think there's a lot of compelling reasons pertaining to lack of efficacy where non-invasive is really not our favored modality. Also, there's significant concerns regarding the risk of aerosolization using non-invasive ventilation. As you may know, the exhalation port for non-invasive leaks to the room. So basically you have a massive amount of aerosolization potentially seen. It's not really potential actually, because we know from the 2003 SARS outbreak that there's a significant risk to healthcare workers and to other patients on the ward when non-invasive ventilation is used. So in a case control study looking at wards in China where patients had SARS infection, the cases were wards where there was a super spreader event, meaning a couple of patients had SARS and within a week, all patients or many patients had it, versus controls where there were wards where patients had SARS, but actually there weren't major outbreaks on those wards. They did a case control study looking at what clinical characteristics, patient-specific characteristics might have explained these super spreader events. And by far, the #1 risk for spreading SARS in a ward was the use of non-invasive ventilation with an odds ratio of almost 12. Other risk factors were beds that were close together, higher flow oxygen therapy, though I should mention the confidence interval here touched 1, or performing CPR, which as you can imagine is a major risk for nosocomial transmission. So when you're failing conventional oxygen therapy, consider high flow. When failing high flow, non-invasive ventilation really should not be our go-to unless it's a very, very compelling reason, meaning a patient has known COPD with hypercapnic respiratory failure, and we think an hour or two of BiPAP might prevent intubation, so very limited circumstances. So the reality of managing COVID-19 at present is that many of these patients who require intubation aren't being managed in an unconventional or non-ICU setting. So on a floor, on a monitored ward that's not really an ICU. And so the reality is that many providers are going to be providing care to these intubated patients in a floor setting. So I think it's very helpful to understand how we approach mechanical ventilation in these patients with some degree of ARDS and COVID-19 infection. Now, I know that Dr. Reddy went through this in excellent detail regarding the specifics of managing the ventilator. What I'd like to talk to you a little bit about is just general strategies for approaching ARDS, in patients who are on the floor. So our general approach to ARDS, especially for intubated patients, includes number one, and this is supported by guidelines from the FCCP. Number one, pursuing a low tidal volume ventilation strategy, meaning as low a tidal volume as the patient's going to tolerate with a pH of greater than 7.3, with the goal of 4 to 8 mLs per kilogram of ideal body weight. So we all know that we generally will target around 6 cc's per kilogram ideal body weight as an initial goal in these patients. But the truth is, if the patient can tolerate lower, that's something that we try to achieve. Aiming for a plateau pressure of under 30 centimeters of water, and I'll talk a little bit more about this in a moment. Aiming for a conservative fluid management strategy. And what that means is watching ins and outs really carefully and being sure that as much as we can minimize ins, whether it's through concentrating drips, avoiding continuous running fluids, knowing that the capillaries in the setting of ARDS are leaky capillaries, all that extra fluid potentially puts the patient at risk for a longer course of intubation. Following the P to F ratio. So the P to F ratio is something that's used frequently in research. It's used to help define severity of ARDS. You basically just take your PaO2 off of blood gas, your FiO2, multiply by 100, you get your P to F ratio. We describe ARDS as mild, moderate, or severe, depending on whether the P to F ratio is 300, 200, or less than 100. This is not something that most internists will need to do on a regular basis for these patients, though in the ICU there are some applications, including deciding when to prone a patient. This is a number we'll sometimes think about. Many of these patients we know, though they do meet criteria for ARDS based on the degree of hypoxia, actually their changes in the lung compliance are not as bad as many of our patients, other patients who have ARDS. And they seem to be very responsive to PEEP and to early proning. So those are kind of our goals when it comes to ARDS management in general. Here are some pearls for kind of applying them practically. So number one, as I mentioned, those 6 cc's per kilogram ideal body weight is our initial target. You can go lower if the patient is tolerating it, as long as in the absence of any metabolic issues, their pH is staying over 7.3. A small degree of hypercapnia is usually tolerated in order to achieve the larger goal of limiting lung injury. The plateau pressure is a source of frequent frustration for providers because measuring it is not something that's necessarily intuitive and not always easy to do. So one pearl I'll give you is that if your peak pressure is consistently under 30, almost always your plateau pressure is going to be under 30. So you don't actually need to worry about checking the plateau. The peak is a function of airways resistance and the plateau pressure, basically. So if your peak is under 30 on a consistent basis and your patient is comfortable and not fighting very hard against the ventilator, then you can pretty much believe your plateau is going to be under 30 and you should be good. When it comes to weaning, I know that Dr. Reddy spoke about this, but just a general principle is when you're trying to wean someone in ARDS off a ventilator, you really want to try to wean the FiO2 before you wean the PEEP. The PEEP is providing a lot of downstream benefit, and we know that excess oxygen comes with its own risks to lung injury to some degree. So as much as you can wean FiO2 before PEEP, we try to follow a stepwise approach to reducing both together, but starting with the FiO2. And the goal is a target FiO2 of under 50 and a PEEP of 5, but obviously try to reach that FiO2 target first. As I mentioned, watching ins and outs in these patients is probably one of the most important therapeutic things that we can do. You really want to try to minimize volume in, whether that means concentrating drips, not relying on drips when you can, trying to use bolus doses of sedative medications and others. Basically just remembering the mantra that dry lungs are happy lungs. It's very, very important in these patients. And lastly, a pearl about ARDS I'll mention is that you and I would not really enjoy breathing in a tidal volume of 300 milliliters. And for a patient who is lightly or not very sedated, with these low tidal volumes, they'll often double trigger and be very desynchronous with the ventilator. And so relatively deep sedation to the extent that's feasible, or sometimes muscle relaxation, which we would not really advise in a ward setting, though we use it in the ICU. But just being aware that deeper sedation than we might otherwise do is often very important in the setting of low tidal volume ventilation. So Dr. Reddy touched on this, and I won't go through it too much detail. I just want to present the fact that ARDSnet, so that's the NHLBI ARDS network, has produced documents that can be very helpful to keep as pocket cards for how to approach weaning in these patients. And this is a strategy that our respiratory therapists often follow. But when I mentioned before that you want to follow a stepwise decrement in PEEP or FiO2, this is what I meant. Depending on your strategy, whether it's a high FiO2, low PEEP strategy, or I would really focus on this bottom set of tables, a higher PEEP, lower FiO2 strategy. These are kind of the ballpark FiO2 and PEEPs that you would want to follow. So if the patient came to you on 30% FiO2 and 24 of PEEP, looking at this, you know, that doesn't make any sense. That PEEP is way out of proportion to the FiO2 the patient should be on. The reality is when patients come in when they're first intubated, for example, in the emergency room, they're usually going to come to you on 100% FiO2 and maybe 10 to 20 of PEEP in the setting of COVID-19 infection. So knowing that, you can kind of use this card to have an idea of, if I have such and such a PEEP, what should my FiO2 be? And I would start with that. If someone is coming to you on 10 of PEEP and their SAT's 100%, you might want to try a lower FiO2 of like 40, 50% just for a minute, standing at the bedside, watching the saturations and see, is that PEEP of 10 really reasonable? And the reality is, while many people think that arterial blood gas is necessary to make these adjustments, as long as a patient's pH and PCO2 are relatively reasonable, your oxygen saturation is a much more valuable and practical tool to make these titrations. And I would suggest using that. And this is going to mean a couple of minutes at the bedside making adjustments. So if someone comes to you with a FiO2 of 50% and a PEEP of 10, well, looking at this, you know, the PEEP is 10 and they're saturating okay in the mid to high 80s. Why don't I try adjusting my FiO2 and my PEEP a little bit to aim for something in the middle, maybe a PEEP of 14 and FiO2 of 40%. Give it a couple of minutes, see what they do saturation-wise. If they're saturating in that goal that we set of 92 to 96%, you might be okay. Get a gas. Maybe set it at that for the next couple of hours or until the next morning. So use these as a rough guide. I think that they're very helpful, and it helps avoid the real problem, which would be a huge discrepancy between your PEEP and your FiO2. And as you're weaning, kind of follow backwards to have a sense of how you can achieve a goal where a patient is ready for trying spontaneous breathing trials. Speaking of that, when are you ready for an SBT? This is a very common question that we get as pulmonologists. There is not a magic answer. It's based on a couple of different factors and a little bit of gut, but some hard data that you can use that I think are very helpful. When your FiO2 is under 50% and your PEEP is less than 5 to 8, you're ready to start thinking about SBTs. Additional factors that are really important, if you were requiring pressors, if you're either no longer requiring a pressor, so your systolic blood pressure is good on its own, or you're weaning very quickly and you're almost off the pressor. Definitely, you would never consider weaning in someone who's under a neuromuscular blockade or paralytic. And a patient is making spontaneous breathing efforts. So if you put them on a 5-minute SBT, they're able to trigger the ventilator. These are the things that you want to think about to say, is my patient ready for an SBT? And then you do the SBT. What is that? So a spontaneous breathing trial, there are many ways you can do it, but generally what I do is, if a patient is meeting these criteria, their requirements are coming down and they are otherwise seeming to be ready, I'll start someone on around 10 of pressure support over 5 of PEEP. The FiO2, again, you want it less than 50% and really as low as they'll tolerate. And I just watch them for a few minutes. If they're immediately failing, they may not be ready for a formal SBT where we watch them for a while. But certainly you can try this, let the respiratory therapist know. And the most important thing is check on your patient, stay with them for 5 minutes, come back after 15 minutes, come back after another 10, make sure the nurse is aware and listening out for alarms. These have to be very closely monitored, but if a patient is improving daily and is able to tolerate your 10 over 5 and you're weaning from there, maybe 5 over 5, and meeting these criteria, they're maintaining their saturation, they're generating a reasonable tidal volume on their own, They're not tachypnic. If you're not sure if they're tolerating it, getting a blood gas can be helpful sometimes with an SPT, though usually we don't need one. But if you get one and they're maintaining their pH in a safe range, these are all signs that a patient is doing well. The last thing I'll mention about the spontaneous breathing trial is, in our current setting, the expectation and the availability for subspecialty support, even respiratory therapy support for every single spontaneous breathing trial, I think that's going to be challenging with the volume of patients that we are anticipating. And so at least assessing for readiness to wean and attempting spontaneous breathing trials with very safe parameters and close monitoring, I think is going to be very, very important on an independent basis. However, I do want to say all of us from pulmonary and critical care medicine are extremely available, especially for cases where there's any doubt about a patient's readiness. Also, I'll mention before considering extubation for patients, especially who don't seem like they're doing extremely well, where there's a question about their readiness, certainly touching base with us prior to proceeding with extubation can be very valuable to prevent an emergency reintubation. So, I think we have to rely on each other mutually, and there's a role for a lot of this being done on an independent basis, particularly assessing readiness to wean and making the decision for extubation. Getting multidisciplinary support for that, I think, is very reasonable. This is a schematic for how to approach hypoxia in the COVID-19 patient, and really, it's just a great summary schematic generated by the group at SCCM, describing everything that we've been talking about. Your patient is admitted. You'll know pretty much up front if they have an indication for endotracheal intubation in the ER. This can change over time, certainly, but up front, if there's no indication for intubation and they're tolerating supplemental O2, close monitoring with the parameters that we mentioned. If they're not, consider high flow nasal cannula as your next modality. If they're not tolerating that, that's really when you have to reconsider, are they going to benefit from endotracheal intubation? And if this is going to be considered at some point in the patient's hospital course, we'd rather do it early than late, just for mainly technical factors, but these patients are much easier to intubate when their saturation isn't starting at 82%. So if we're going to intubate, we would really rather do that early. And I would just use this as a general reference. Similarly, also provided by SCCM is just a general approach for important checklist factors depending on the severity of ARDS in our COVID-19 patients. I won't go through this now, but just have this as a reference for kind of your checklist for the day for patients with the ARDS in this setting. So finally, I want to talk a little bit about modalities of oxygen delivery, really briefly. There's so many things you can do short of high flow nasal cannula, and there's often confusion about when to employ them. So I just wanted to talk a little bit about this. So everyone is familiar with nasal cannula, of course. Each liter of oxygen is about 4% FiO2 over 20%. This isn't exact. It really depends on whether the patient is breathing 100% through their nose, how tachypnic they are, other factors, how much room air they're entraining, basically. But as a general rule, if you're on 1 liter of O2, your FiO2 is 24%. If you're on 2 liters, your FiO2 is around 28%. The biggest caution that I can give is to be careful in indiscriminately using a nasal cannula in a patient with baseline hypercapnia. If we think way back to medical school residency, the alveolar gas equation, where you have your alveolar O2 on one side, your FiO2, on the other side of the equation, you can change the FiO2 and your alveolar O2 will get better, but it will do nothing for your CO2. And so though your saturation will probably improve in a hypercapnic patient that you put on a nasal cannula, your PCO2 could be going up. You just have no idea until the patient is potentially in distress. So in patients who are at risk for hypercapnia, have known baseline hypercapnia, who are getting sedation for whatever reason, I would say use nasal cannula very judiciously. And wean aggressively, just target a saturation of 92%. The last thing I'll say about this is, if you're worried about hypercapnia in the patient and they're on room air and their saturation is over 92%, don't worry about their hypercapnia. It's almost impossible to be hypercapnic on room air with a decent saturation. And so that's why, the first thing I do when I walk into the room when I'm rounding is to turn off the oxygen and see what happens to the saturation. I think it's a very valuable and easy way to assess your patients, to wean aggressively. So next, the Venturi mask. We don't use this a whole lot at Montefiore, but I think it's valuable mainly in your patient who's mouth breathing, where a nasal cannula might not be so effective. So the Venturi mask basically is taking 100% oxygen and diluting it with different amounts of room air. And depending on the degree of dilution, you get a different FiO2. Each of these colors is like a different set FiO2 it's written on there. Similar caution in patients with baseline hypercapnia. Just a little trick about this, the louder it is, the lower the FiO2 because more room air is being entrained basically. And a Venturi mask, I would not really use it too often, except if you have a patient who's really mouth breathing, not hypercapnic, otherwise doing okay with supplemental O2. And these are often humidified, but in the setting of COVID-19 infection, we would really recommend avoiding humidification. Even if it's a little uncomfortable for the patient, from the perspective of aerosolization, it makes it much safer. So next is the non-rebreather mask. So the non-rebreather, as we all know, delivers 100% of FiO2 for the most part. Depends on how tachypnic the patient is and whether this reservoir bag is full. I would recommend thinking of it as the mask of last resort, whether or not a patient has COVID-19 infection. Interestingly, though, in patients who do have COVID-19 infection, many of them seem to tolerate this pretty well, and some can actually be weaned prior to requiring intubation. So I would say we could probably use this more aggressively in this population than in your average patient. But usually, to me, a patient on a non-rebreather on the ward is a sign of a patient who is failing and might require other interventions and evaluation kind of in an urgent way. To make sure your non-rebreather is really working, make sure you set your wall flow rate, the little green knob on the wall, to greater than 12 liters per minute, and make sure that this bag is at least partially full. If it's empty, you don't really know what the FiO2 is. It's a combination of 100% and room air to some degree. High-flow nasal cannula. So we talked about this. Basically, with high-flow nasal cannula, there's two things you're setting. You're setting a flow rate anywhere from 20 to 60 liters per minute, and you're setting an FiO2 of anywhere from around 30 to 100%. And it delivers warmed, humidified air. I mentioned that we try to avoid humidification, but delivering 60 liters per minute without humidification is really difficult and very, very uncomfortable and unsafe for patients. So in this case, probably is necessary. There are different approaches to how to manage these patients about whether they should wear a mask with high flow on or not. If they're tolerating it, I would say a surgical mask on top of the high flow is not a bad idea. Advantages of high flow and the reasons we like it, it provides a very small but helpful amount of PEEP and expiratory pressure. So it's helping to recruit lung segments that may not otherwise be open. And it also, believe it or not, supports ventilation, but to a very limited degree. So what is ventilation? It's the ability to offload CO2. If the CO2 content of your anatomic dead space of your mouth, of your oropharynx is lower because it's being washed out by the high flow, well, the gradient for CO2 offloading is much more favorable. So to a very limited degree, even for a mildly hypercapnic patient, actually, I really like high flow because of this dual effect. So use it liberally and, consider it before, for a patient who's failing conventional oxygen therapy. CPAP has a very, very limited role in the management of patients with COVID-19 infection and really no role in the management of ARDS. Basically, you're setting two things. You're setting a single continuous pressure and you're setting an FiO2. This is really ideal for your non-COVID-19 patient with OSA, whether diagnosed and managed with CPAP at home or not. Provide some degree of pneumatic stenting of the upper airway. And assuming that patient does not have severe baseline hypercapnia or hypoventilation, in which case BiPAP may be more appropriate. The other major indication for CPAP is a patient with systolic heart failure and cardiogenic pulmonary edema. In systolic heart failure, though not necessarily true in diastolic heart failure to the same degree, we know that this can reduce preload and afterload. And to a very limited degree, there's a change in hydrostatic pressure at the alveolus. That's a minor, almost negligible effect. But really, the changes in preload and afterload really favor improvement and resolution of cardiogenic pulmonary edema. So CPAP, limited uses, but some very good ones. So BiPAP. I think I spoke at length that this should really be avoided in the setting of COVID-19, but it has a lot of other uses. What do we set? We set a PEEP, which is the EPAP. You set an inspiratory pressure. You set a rate, which is a backup rate. The patient can breathe independently at their own rate, and FiO2. And it can be given through a number of masks: nasal pillow, nasal mask, full face mask. It's ideal for patients with hypercapnic respiratory failure, either acute, chronic, acute on chronic. For acute indications in a patient who's not using BiPAP because they use it every single night for their obstructive sleep apnea, I would say be very, very careful, especially in the initial phase of their illness, that you're watching their blood gases carefully and making titrations, which I'll describe now, based on those blood gases. If the patient is not very hypoxic, if their major issue is their hypercapnia, usually you don't actually need an arterial blood gas every single time. A VBG is close enough and will give you a trend in their CO2 and pH. So the difference between the IPAP and the EPAP is the gradient for ventilatory support. The bigger the difference between these two numbers, the more support you're giving to offload CO2. Unlike in a mechanical ventilator, where when you set someone to pressure support 10/5, they're really getting 15/5. These are absolute numbers on the BiPAP, the V60 BiPAP machine. So 10/5 is 10/5. The difference is absolute, the difference of 5. So the IPAP you can set it initially anywhere from 5 to 30. The EPAP, which is the PEEP, you can set anywhere from 5 to 15. The number that almost everyone starts with is 10/5, and you kind of titrate from there. If a patient is oxygenating well on 10/5, but their CO2 remains kind of a little more elevated than you like, so they come in at 100, start 10/5, the PCO2 is still 80, the pH is still 7.18. You might increase the IPAP only to 15, so that'll give you a gradient of 15/5, which is a difference of 10 rather than a difference of 5. So as I say, the differences in IPAP relative to EPAP are what's really the amount of help you're giving the patient. You can look at the tidal volume that's generated, mostly by the patient, just with the support that's given, and that's also really helpful. That plus the minute ventilation give you a sign of whether you're providing effective ventilatory support. If someone is so dependent on BiPAP that you're worried that even disconnecting them from the mask is going to result in clinical worsening, that's really not a great indication for BiPAP. That's a sign of a patient who probably needs to be intubated. Similarly, in a patient who's very lethargic or in whom otherwise the risk of aspiration is very high, BiPAP or CPAP are not ideal modalities because the risk of aspiration is even higher when you're blowing their stomach full of air. These are really not designed for continuous 24-hour use for the most part. Finally, mechanical ventilation. So Dr. Reddy spoke about this in great detail. The only mode of mechanical ventilation that I'd like to talk about now is something called AVAPS. So AVAPS is a mode of mechanical ventilation that's actually done with our conventional BiPAP, also called V60 machines. So the BiPAP that you've seen on the wards many times can actually be used to provide ventilatory support. Per the manufacturer, it's not designed for a deeply sedated, non-triggering patient. It's really just for a patient who's able to trigger spontaneously. And it works via an endotracheal tube. So this AVAPS mode, what is it? It's not something that most of you, or even most of us, really use with any regularity, but it's average volume assured pressure support. Basically, what's happening here is you set a goal tidal volume. Hopefully it's not 883 unless your patient is 7'6", but you set a goal tidal volume. You set the pressures that you're willing to tolerate to generate that volume. So a minimum and a maximum pressure, and you're setting a PEEP. So basically, if I had a volume of 400, and I know I want my peak pressures to not be too high because I don't want my plateaus to be too high, I might say, okay, I'm going to set my minimum pressure to 15, my maximum to 25, and I want to generate this tidal volume of 400. So the machine knows the acceptable parameters of pressure that it can use to generate your goal tidal volume. And over the course of a minute, it'll try to average out a volume to what you've set. The rate is a backup rate. It's actually set by the patient, but if a patient is not triggering, it will actually provide a backup rate. And then you also, of course, set an FiO2. So with all of these values, in a mildly or moderately sedated patient who can still trigger, AVAPS mode for a relatively stable patient is actually quite appropriate with close monitoring. Where it's usually used, just for background, is in a patient who has a neuromuscular disease and is requiring some ventilatory support that may vary a little bit day to day, but doesn't vary significantly. Where it's not great is in a patient with very dynamic lung compliance, meaning day to day they could be getting much, much better or much, much worse, in which case the amount of monitoring that's required is actually prohibitive, and that patient should probably be on a conventional ventilator that alarms like a conventional ventilator does and can do different modes. But AVAPS for relatively stable patients, this is something that you may actually be seeing and managing on the floor. So basic approach, I'm just going to wrap up here. Basic approach to the hypoxic COVID-19 patient. Here are the things that I would think about when you get a patient triaged to the floor. Make sure that they've had a chest x-ray, EKG, ABG. just for, basic workup for hypoxia in general. Patients with COVID-19 and those without can have other issues going on, and you want to make sure you're not missing some other etiologies for hypoxia. Really try to avoid a CT chest in these patients. They're really interesting to look at, but it results in, number one, additional exposure. Number two, the CT room has to be closed for 2 hours afterwards. And number three, they really don't add much to clinical management for these patients unless you have a really compelling reason to think of another diagnosis. So if you're worried about a PE and there are compelling reasons to think so, try to avoid CT chest in these patients. Have a very low threshold to start antibiotics, whether for a community-acquired or hospital-acquired pneumonia. Because the risk of secondary bacterial pneumonia is very high in these patients. And this presentation can be subtle because they do come in with an abnormal X-ray and hypoxia. As I have mentioned, maintain a minimum supplementary oxygen level to maintain a saturation of 92 to 96%. If that fails, escalate to high flow nasal cannula before considering a non-rebreather. And high flow nasal cannula, if it's available, can generate an FiO2 of 100. So if the patient is requiring 100% high flow nasal cannula, this is a point where it would be very reasonable to touch base with your colleagues in pulmonary and critical care medicine, who would be very happy to provide further input and assistance at that point. Avoid non-invasive ventilation, please. If a patient has underlying small airways disease, COPD, or asthma, try to switch all of their nebulizer therapy to meter dose inhalers to minimize the risk of aerosolization. If a patient is in distress on oxygen therapy, even if their saturation is normal, and particularly if they're lethargic or tachypnic, check a blood gas, which is going to be really critical to informing management. And please call us. And if a patient's on mechanical ventilation, you can consider a daily ABG to aid in titration. These are really helpful to us if they're obtained in the morning, if we're providing input on a given patient. However, I would say if the tidal volume and the rate are relatively stable, if the patient's comfortable, and if they're overall improving especially, oftentimes just using your oxygen saturation, you can use that to help guide changes in FiO2 or PEEP on the ventilator. So that's about it as far as managing ARDS and managing hypoxic respiratory failure in these patients in general. I would encourage everyone to take a look at the SCCM guidelines on the subject, which cover everything regarding management of hemodynamic instability, management of antibiotics, management of respiratory failure. It's a really, really comprehensive set of guidelines. Here's a QR code to access them. And I wish everyone the best of luck in caring for these patients, and I'm confident that we'll all pull through this together. And look forward to working with you in the months to come.